Moving on to the indications for laparoscopy and hysteroscopy. We know that laparoscopy will be required, as I mentioned in the section on tubal factor, if we need to remove a hydrosalpinx. It would also be needed to treat a case of endometriosis, especially if you see what is called as chocolate cysts in one or both the ovaries. If there is a suspicion of adhesions or tubal block which could be treated laparoscopically before the patient goes for IVF, the removal of fibroids and other coincidental pelvic pathology which could be causing infertility. Hysteroscopy is required for those patients where ultrasound has shown the presence of a polyp or a septum or a submucous fibroid or intrauterine adhesions or any such pathology which is likely to impede the IVF outcome and which needs to be corrected before beginning or embarking on an IVF cycle. We also know that for polycystic ovaries, sometimes you are recommended to have a procedure known as ovarian drilling, wherein several holes are burned into each ovary with the intent of reversing your hormonal imbalance and re-establishing normal ovulation. The decision to do this should be taken after mutual consent between the patient and the doctor, after understanding all the pros and cons of the procedure and the risks which are involved too. Similarly, for endometriosis, repeated surgeries are not advisable because this would greatly affect the egg reserve. It would bring down the egg reserve and thereby impede the IVF performance at a later date. With fibroids too, remember, not all fibroids need to be removed before IVF. Only those which are submucosal, meaning they are impinging in the uterine cavity, protruding in the uterine cavity exactly at the location where we would subsequently be replacing embryos, only then you need to remove these fibroids and then proceed with the IVF cycle. So these are some of the indications for laparoscopy and hysteroscopy in an infertile patient.